Paraplegia. Paralysis of both the lower limbs without any involvement of the upper limbs is called as paraplegia. Causes: upper motor neuron lesion. Intracranial causes: this occurs very rarely. Tumors of the falx cerebri. Thrombosis of superior sagittal sinus. Thrombosis of unpaired anterior cerebral artery affecting both leg area. Spinal causes: subacute combined degeneration of the cord, multiple sclerosis, acute transverse myelitis, motor neuron disease, amyotrophic lateral sclerosis, fracture dislocation of the thoracic or lumbar vertebrae, epidural abscess, vascular causes like hemorrhage, thrombosis, arteriovenous malformation, compression of the cord by space-occupying lesion, radiation myelopathy, POTS paraplegia following tuberculosis of the spine, hereditary spastic paraparesis, trauma, lower motor neuron lesion, anterior horn cell lesion in conditions like poliomyelitis, spinal muscular atrophy, and motor neuron disease, roots lesion like cauda equina syndrome. Peripheral nerve lesions such as in neuropathies, polyneuritis, myasthenia gravis, muscular conditions like muscular dystrophies, polymyositis, spina bifida with myelomeningocele. Clinical presentation: in lesions that are acute like acute transverse myelitis, there will be a stage of spinal shock. During the stage of the shock, the tone of the muscles are reduced, flaccid or hypotonicity. The reflexes are absent, areflexia. Atonic or flaccid bladder will be seen, and hence the patient will be totally dependent on others for his activities of daily living. After the stage of shock has passed, the lower limbs will present with either upper motor neuron or lower motor neuron type of paralysis depending on the level of lesion. Lesion in the cauda equina will present as typical lower motor neuron type of paralysis. Thoracic or higher lumbar lesion will show lower motor neuron type of picture at the level of lesion and upper motor neuron type of paralysis below the level of lesion. To understand the above statement, let us consider that the patient has involvement of L2 and L3 spinal segments. In this case, muscles having their root values as L2, L3, like the quadriceps, will show lower motor neuron type of lesions, whereas muscles with root values that is lower than the above, like L5, S1, S2, etc., will show upper motor neuron type of presentation. Paraplegia in flexion and paraplegia in extension. It depends on intact connections between the reticular formation, nuclei, and the spinal cord. If the spinal lesion is partial so as to spare the reticular spinal tract, extensor hypotonia predominates. Occasionally, flexor withdrawal reflex is elicited on giving noxious stimulus. If the spinal lesion destroys not only CST but also RST, flexor withdrawal reflex is freed from its antagonists and shows domination. The involvement of vestibulospinal and rubrospinal tract also determines the presence of paraplegia in flexion or extension. Complications of paraplegia: pressure source. In case of chronic illness with paraplegia, the patient is bedridden for a long time. If proper care is not taken, patient develops pressure sores, which becomes a major complication if infected. Tightness and contractures. Because of the inability of the patient to move the lower limbs, patient's lower limbs are positioned under the effect of gravity or under the influence of spasticity. This position, if continued for a long time, leads to loss of physiological excursion of soft tissues. The patient suffers from tightness, contractures, and loss of range of motion. If these are not treated in time, it will lead to fixed malalignment of joints, which eventually will lead to deformity. Impairment of tone. Depending on the level of lesion, the patient presents with either flaccidity seen in low motor neuron type of lesion or spasticity seen in upper motor neuron type of lesion. Abnormal alteration of tone affects the normal movement of the lower limbs and leads to abnormal gait patterns or loss of ambulation. Osteoporosis. Without adequate weight bearing imposed on the lower limb bones, more and more calcium is released from bones, which causes osteoporotic and fragile bones that is prone to have fractures even with travail trauma. Urinary complication. The common urinary complications that the patient can develop are urinary tract infection and renal or bladder calculi. Urinary retention or dribbling coupled with poor hygiene increases the chances of infection in the urinary tract. As the patient is bedridden, the absorption of calcium by the bone is reduced. This causes accumulation of calcium in the blood that eventually gets deposited in the kidney, causing renal calculi. Respiratory complications. Higher thoracic level lesion that causes paralysis of respiratory muscles like the intercostals and the abdominal will cause a gross reduction in the vital capacity of the patient. Furthermore, the weakness of the abdominal muscles causes a very ineffective cough which allows the secretions to get accumulated, hence causing secondary infection. Depression. As the patient is no longer a contributing member in the family, he develops a complexity about himself and hence goes into a state of depression which adds on to his physical disability. Physiotherapy management. The aims of the physiotherapy management consists of prevention of all secondary complications as a result of being bedridden, restoration of functional independency to the maximum possible limit, psychological counseling, social and vocational rehabilitation, family education and home adaptation. Counseling. A patient who is depressed cannot cooperate with the therapist, which will have a negative effect on the overall rehabilitation of the patient. Hence, to gain maximum cooperation from the patient, the therapist should give appropriate psychological counseling that will enable the patient to come out of the state of depression. The patient needs to be told regarding his condition, but at the same time, the therapist should try and highlight the positive features contained in the patient even at this stage, which in turn will inspire the patient to look at his future in a more convincing manner. However, one should not give false hopes to the patient as the expectation of patient may be too high. Interviews or articles of paraplegic patient leading a relatively independent and even successful life will help in changing the patient's mental state. Maintaining passive and active range of motion. Patient's lower limb should be moved passively by the therapist through full range of motion if the patient is not able to perform the movement actively. Wherever the patient is likely to put his active efforts to perform the movement, the therapist should encourage it as this will not only maintain the active range but will also help the patient to maintain the properties in his muscle. Passive movements need to be given every 2 hourly, hence the patient's relatives attending him should be taught the correct way of handling and giving passive movement without producing undesired movement of the spine. Passive movements helps to maintain the normal physiological length of soft tissues and prevents tightness. It maintains the memory of the movement pattern in the brain, which may help in the later stages of recovery. Passive movements also help in reducing spasticity if given in a gentle, slow and rhythmic manner. Along with passive movements, all the biarticular muscles of the lower limb should be stretched. Maintenance of good bronchial hygiene. As a patient is totally bedridden, it leads to deconditioning of the respiratory system. Moreover, in high cord lesions due to respiratory muscle weakness, the patient needs ventilatory support, which further increases the chance of lung infection. Hence, proper lung hygiene should be maintained by given proper positioning, nebulization and a regular suctioning. If the patient is not ventilatory support, then he should be taught breathing exercises and encouraged doing it every hour. Care of skin. Due to constant immobilization of the patient can develop pressure sores at certain body parts. Certain areas are more susceptible to develop pressure sores like sacrum, heel, lateral aspect of the knee, occiput, etc. Hence, prevention and treatment of pressure sores are very important. Prevention of pressure sores is achieved by undertaking the following measures. The patient's attendant as well as the nursing staff should be advised to keep changing the position of the patient every 2 hours to avoid increased weight bearing pressure on certain body parts, especially where the subcutaneous fat is very less. Good skin hygiene is maintained by giving regular sponge bath and applying talcum powder, as a patient with urinary or fecal incontinence are prone to soil the skin around the genital area. It is very susceptible to cause skin infection and even urinary tract infection. Hence, more emphasis should be given to those areas to maintain hygiene. Bed linen is kept dry and free of creases. Beds that bring about a more uniform distribution of body weight should be given. Thus, waterbed or airbed is used to equalize the pressure on patient's body and to prevent areas of increased pressure. Gently massaging the pressure susceptible areas also increases circulation in that areas, preventing the chances of skin infection. In spite of the entire preventive measures, if the pressure sores do develop, then it should be treated at the early stage and the wound should be prevented from getting infected so that the rate of healing is faster. This can be achieved by the following: regular dressing of the wound, cryotherapy around the wound area to increase circulation, infrared therapy over the wound also increase the blood supply to the part and thus helps in faster recovery. If the wound is infected, then UVR can be given. Laser therapy at appropriate dose can be very effective in healing the sores. Direct current given at the edges of the sores helps in healing. Care of bladder. The patient is taught self-cleaning techniques and intermittent catheterization. For low motor neuron type of bladder, Valsalva maneuver or Creed's maneuver is taught. For patient with upper motor neuron type of bladder, intermittent catheterization technique or timed voiding program may be given. Active exercises. As soon as the patient shows signs of active contraction of muscles and active participation, all the exercises that needs active cooperation of the patient should be started. These exercises are essential to make the patient functionally independent. The common exercises which is incorporated into the treatment program consists of mat exercises, strengthening techniques, weight bearing exercises, normalizing tone in the lower limb, gait training and transfer activities. Management of spasticity. Refer chapter 2. Mat exercises. To prepare the patient for gait training and erect posture, mat exercises play a very important role. These exercises consist of those activities that may help the patient to achieve some functional independency. The activities consist of turning to each side, rolling and bridging. Similarly, in prone position, the patient may be given activities such as coming onto forearms, coming onto extended forearms, quadrupedal position with the help of some external support, kneeling with support, half kneeling, etc. Strengthening exercises. These consist of exercises to strengthen the lower limb muscles in case of lower motor neuron type of palsy. Strengthening of the upper limb is essential as this will help the patient to enable efficiency in activities like transferring, use of walking aids like crutch, and also helps in overall functional rehabilitation. Strengthening of trunk muscles is essential for better trunk control and stability, which will help in better balancing in sitting or standing. Quadratus lumborum is the most important trunk muscle in case of paraplegia who have got no hip flexors because it enables the patient to hike the pelvis and clear the paretic limb off the ground, thus enabling the patient to be ambulant. Use of tilt table. In the initial stages, when there is no trunk stability, patient can be trained for weight bearing on lower limbs by using tilt table. In this, the patient's trunk and the lower limbs are strapped to the tilt table and then the table is tilted such that the patient is in erect position. Moreover, tilt table can also be used in the initial stages to prevent the chances of orthostatic hypotension. For preventing hypotension, in the initial stages, the patient is made to lie on the tilt table and the table is gradually tilted every day at increasing range so that the autonomous nervous system is made to get conditioned. As a result of the reflex vasoconstriction can be stimulated in erect position. This will help in preventing or treating orthostatic hypotension. Transfer activities. To make the patient independent in ADL, it is necessary to train him to use the wheelchair and transfer from hand to wheelchair. Easy ways of transfer from bed to wheelchair, from wheelchair to low stool, and from low stool to floor and back to wheelchair should be taught to patient. The patient also should be trained for balance in sitting position if his trunk muscles are affected. Patient should also be taught various ways of locomotion in emergency situation like shuffling in sitting position, semi-crawling in prone position with the help of weight bearing on the forearm. Gait training. Paraplegic patient can be made to ambulate with the help of crutches and calipers. There are various types of paraplegic gait that can be taught with the assistance of auxiliary crutches like shuffling gait, dragging gait and swing gait. However, walking should be trained in a gradual manner. The lower limbs are supported with appropriate orthosis and the patient is made to stand in the parallel bar. The patient is advised to do hyperextension of the hips and trunk to maintain erect posture and balance. Hyperextension of the hip locks the hip with the help of ischiofemoral ligament and thus provides stability with. Once the patient is confident in standing, gait training is started by instructing the patient to lift one leg and take weight on other extremity. Stepping forward is taught next and the physiotherapist progresses to walking in parallel bars. After this, patient is made to walk out of the parallel bar with the help of walker. Depending on the trunk stability and confidence of the patient, progression can be made to auxiliary crutches. Elbow crutches or cane can be given only if the upper limb musculature becomes quite strong to weight bear efficiently and within the safety limit of the patient. Even if the patient is not going to be a community walker, it is important to give him gait training so that he can achieve some independency in activities of daily living and to maintain his self-esteem. Weight bearing on the lower limbs in erect posture also acts to slow down the process of osteoporosis and prevent tightness. Use of orthosis or appliances. Lower limb orthosis or gaiter may be used depending on the muscular status in the lower limbs. Social and economical rehabilitation. The therapist should not only aim to give physical independence to the patient but also aim to provide him with the sort of economical independency so that he feels socially acceptable. This is very important, especially in younger individuals who have family members dependent on them. A group approach including physiotherapist, occupational therapist, social worker and patient himself form a team and the contribution of everyone is important. Since the end user is the patient, the motivation and morale of the patient should be kept high during the whole process. The patient should be provided a job he is interested in and is able to manage with his physical disability. Since the patient is a paraplegic, he may be used to perform those jobs that involves the skill of the upper limb. Having a good trunk control will be an added asset during this stage of vocational rehabilitation. With the emergence of software technology, the employment opportunity has increased in recent years for this kind of disabled patient. Vocational training may be implemented if the patient doesn't have a particular skill necessary to have a job. Carvings, embroidery, computer jobs, and other forms of desk work can be taught to the patient. Once the patient earns his living, it will not only give him economical independence but will also keep him engaged so that he no longer keeps thinking about his impairment but focuses his attention on a much more positive aspect of life. The overall rehabilitation of the patient depends upon his motivation and determination along with skill, perseverance of the therapist. Thank you.